Parang has graciously agreed. Thank you, Lisa. Parang has graciously agreed to supervise some students, and then another colleague of ours, Erin Mayer, has volunteered to identify those students and sign them up. So that is something I would like to sort of settle before the hour ends, moving forward that process and decide what type of notes do we want them to look at, and then logistically, how do we make that happen? We've done this for a variety of projects. The clinical warehouse team has done this for a variety of projects in the past. I would say the institution's preference, not just our preference, is that work happen on site. And so our plan is to have students from Norman come to the Health Sciences Center. We need a place for them to land, be able to access file servers where we store these clinical notes, and then they can review them and do the manual chart abstraction. All right, so I'm getting ahead of myself a little bit, but I do want to talk more specifics on that towards the end. For Rodi's sake, I guess, Parang, you want to briefly introduce yourself?
Hey everyone, my name is Parang. I am a professor in quantitative psychology in the Department of Psychology at the Norman campus. And my expertise is on data analysis and psychometric assessments, and substantive research wise, I'm very interested in the health outcomes, including the mental health outcomes among children, adolescents, and young adults. I have worked with David for quite a bit in the, I don't know, maybe 2 years ago. It was before pandemic started, and managing a small team over there, methodological core over there. So, and yeah, I'm excited to be part of it and ready to learn a lot more from all of you guys. Thank you.
Yeah, thank you for that, Parang. And yeah, so I skipped over that most important piece, that not in addition to her supervision of these students, she's a quantitative specialist, so she'll be analyzing the data for us. I'm going to presume you know Dr. Brand. How about Geneva and Ashley?
Yeah.
Introduce yourselves.
Hi, I'm Ashley Freeman. I work with the Clinical Research Data Warehouse. We help a number of different faculty across campus extract data for their research interests. And then I also work in the section of general pediatrics.
We haven't seen you for a long time. Hey, Geneva.
Good to see you.
Oh, I hate it. COVID.
I'm Geneva. Same deal.
There's another actor behind the scenes who couldn't be on today. He's on another call, but Will Beasley, who manages the clinical data warehouse. And so he's been very busy on this, helping Geneva and Ashley pull together the data we're going to show you in just a minute. Lisa's on too, and she's helping us coordinate all this. So you'll see emails from her in the future for when we get back together.
Yeah. Hi, everyone.
We do have another faculty member who couldn't be with us today from College of Public Health. June is a health economics expert, and so she's looking at the data from the dollar figure perspective. And this is sort of what one of the initial conversations I had with Nelson Agudelo was a paper that was published last year looking at the cost of patients with endocarditis who came through systems. Actually, no, let me back up a little bit. It was more broadly patients with IDU, some of which had endocarditis and others had other types of health concerns. And he wanted to kind of replicate that. So June has agreed to help us pull together some of those same cost figures and apply it to whatever we come up with on the patient side. Okay, I think I cut you off, Rodi, but I bet you were going to give us a brief description of your role.
Yeah, so I am a devout clinic coordinator. I'm a clinical nurse specialist, which is an advanced practice nurse who specialized in cardiology. I've been a cardiac nurse since 2000, 2001. I finished my master's in 2006, worked in all kinds of cardiology. Initially, I worked with the cardiac surgery aspect of it up until 2006, then cardiology when I became a provider. And I started out with transplant cardiology and heart failure. goes together, I guess. And then went into more diversified interventional, and then volunteered to do a TAVR program, started TAVR, which is TAVR is a less invasive route of doing the aortic valve replacement without having to open the chest. So they put it into a vessel in the leg. And although this would not be, this is off-label for endocarditis patients because they have big infections in their heart, and got to get those out. But that's how I got into all this. And so in 2014, I moved to Tulsa, or Oklahoma City from Tulsa, and started the valve program. We don't have a lot of older patients here, so ended up, in order to build it, you kind of embrace what you've got. And we have a lot of endocarditis. We have a much younger population. So and these patients obviously have a lot of needs. They're very poorly compliant, and readmission rates are really high. They go AMA, against medical advice, a lot, and we have never really fired any of them. I don't think that has, anyway, they a lot of them, some of them will bounce back, some of them you don't see for a couple of years, and they come in. It's an interesting group of patients, but it is a population that we're unique in that fact that when I worked in Tulsa, I worked at two of the larger hospitals, St. Francis and St. John's, and we might have seen one or two endocarditis, patients per year. Here, a lot, 20 to 30 maybe, and that's the ones I get back to the clinic. There are way more that come through the hospital, get diagnosed, and go and never come into follow-up. So since COVID started, it's been harder to connect with these people before they go home. I think that's a big aspect, but from I'm going all over the place, but so from a institutional support aspect, it will be, if we can figure out what works and what doesn't, and then present the dollar signs. There's a lot of money to be, if we can streamline this, there's a lot of money to be saved, and if we can get these patients through and then support them. And we follow these patients long. I've not, even in patients who have been treated, I continue to follow, just because you learn, you learn from them, and who did well, and if they bounce and they relapse, and what were the triggers. Anyway, there's all kinds of different data points I guess you could consider. But I guess keeping them in the hospital for completion of treatment, you tell me where we want to start with, but that would be one. A lot of them leave and then they have an incomplete course. They come back and you have to start the course all over. So you end up with maybe a month and they need 6 or 8 weeks, and then they come back, you got to start that all over. And you think of all, and they're usually uninsured. So anyway, I just kind of came to it because that's what we have. Our population, we have, and the majority of them here, historically endocarditis used to be due to dental, in fact, bad dental hygiene, but it's definitely more prominent in the drug use now that that's gone. That crisis is kind of gone up. Anyway, I don't know what more specifically there's all kinds of different avenues you can go with this. It's interesting though.
No, that historical context helps a lot. Thank you. And in fact, I'm going to ask Dr. Brand to sort of chime in and describe his involvement with the clinic. And this is, I'll be honest with you, I'm only loosely familiar with the clinic operation. When Nelson and I first started having these conversations, it sounded like the clinic evolved at some point within the last, I thought it was fairly recent, 2018, 2017, and it became more interdisciplinary. And I know he sent me papers on the benefits of having interdisciplinary heart valve clinics. That was sort of the impetus for the project, that when the clinic transitioned to being interdisciplinary, do we see better outcomes than we did before for some of these patients? I'm actually, for sake of the project, certainly not for society, but for the sake of the project, I'm glad to hear we do have a lot of these patients in our system who may not show up for that follow-up. And it sort of verifies what we found in these preliminary looks into the warehouse, as you'll see in just a moment. But Dr. Brand, you want to tell us about your team's involvement with the clinic, when that started, and exactly what type of services you provide? We can't hear you for what it's, I see your lips moving.
Yeah, I was trying to be quick and smart, which would be a challenge for me. So yeah, so Roddy really started the interdisciplinary, clinic, and it's more than just an interdisciplinary clinic because it's a model where the providers are there and the patient comes to the providers. And initially we were doing this, we weren't sending patients all over the place. I mean, the dentist was there, Agudelo was there, Pacala was there, I was there. I mean, the whole crew was there, and basically the patient came there and then saw whoever they needed to see, which is a pretty unique kind of concept. And so Roddy started that. Then because of the endocarditis and the intravenous substitutes, they asked us to see if we could help. So these were really train wreck cases. I mean, they're some of the worst sounding cases of the worst sounding cases, and a lot of ended up with death. But so we started, meaning I started coming over there. It's been about a year trying to kind of figure this out. And then we got some help with some interns, and now Frida's over there, and she's over there as much as she can be. She's in LMSW and working. And so that was an integrated behavioral health piece. And so the idea was we were going to help with all these endocarditis folks. And like I said, they are high utilizers, poor outcomes. What we did find was that there were a whole lot of other people over there who had mental health problems, and what I would call kind of lower grade substance use problems that were probably working against their endocarditis or their heart condition. And we just kicked over a ton of rocks. People had anxiety, they had depression, they were using alcohol excessively, using methamphetamine, any number of kind of things, kind of low grade stuff. And then we looked at what we could do to pay for that. And so the integrated behavioral health is offered or paid for by a lot of private insurances, and it's paid for by Medicare. So we work with the billing folks that initiated the idea being that the paying customers, we could provide integrated behavioral health for them that would help subsidize the LMSW, LCSW that was over there. And then in turn, they would also be there to help with the really bad cases that were high utilizers and were poor outcomes. Now then, Roddy and I could probably point to a slew of folks who had good outcomes, who had endocarditis and intravenous drug use, and point to them. And we can point to some that didn't work out really well. And then there's a whole bunch in the middle that had, like I said, mental health problems and or some lower grade substance use problems that we picked up, that we've treated it. And so I don't know how they're doing it now. Pacala left, but one of the things we did was, I haven't seen this in a lot of clinics, but we did kind of group interviews. I mean, we interviewed the patient together. There'd be 3 or 4 of us in the room, each taking our little part and putting the picture together for the patient, which I think was much slower than most clinics function at, but was much better for the patient in terms of the treatment being truly integrated, and I think compliance was better. So anyway, that's kind of where we are, or how I got involved in the clinic and where things are. We kept, I think we're doing it internally now, but we kept for a while. We have to do this for Medicare, but a database of patients and PHQ-9 scores and GAD scores, and how often we intervened with who and what. And so we've got that data separate from what's in the chart, but it's in the chart as well. So I think there's a chance to look at endocarditis and ineffective drug use. And there's also a chance to look at, integrated behavioral health from a case, integrated case management perspective, and to see, does that pay off or not? And putting dollars and cents to it, I think will be a challenge, but it'll be worthwhile for an actual case. So anyway, that's kind of it for me.
Yeah, that's fascinating. When did the clinic start? The valve clinic? Early days.
2014, like May 31st, anyway, somewhere in there.
And we didn't have anything like that prior to the start of the clinic?
No. There was one girl that had the job before me for 2 months, then quit. That's it.
What do we do with patients like this who arrived prior to 2014?
So when I did a retro analysis on the 2013, most of the patients were operated on as inpatient, and they had one outpatient that was done. I don't remember what the mortality rate was off the top of my head, but I know it wasn't low. Whenever heart surgery outcomes are much better when you operate electively as an outpatient than they are urgently as an inpatient, which I know seems intuitive. But the patients would follow up in separate clinics with cardiology and cardiac surgery at separate times, and there would be very little collaboration or coordination, whatever word you want to use, between the two. So as the coordinator, myself or one of the nurses here, we try to serve as like the middle, the one who we try to go in with almost win the visits with the patients and be that point person, and then try to pull in which provider or providers need to see the patient at the next visit. And so the provider and the nursing stays the same, or the patient and the nursing stays the same in the location. So they develop this comfort zone, because a lot of them have a lot of apprehension about going, there's anxiety, mistrust, they feel judged. I mean, those are just things that I hear from the patients a lot. But we do eventually get pretty good return once they start coming and develop a comfort here. But I guess the arena of the providers coming to the patient usually, you do that as an inpatient, you get different, the patient's in a room and everybody goes and finds the patient. But, these patients going to, 4 or 5 different specialists, if they had an infection in their spine, they got a neurosurgeon, they have a cardiologist, internal medicine. But here we're trying, we bring the patient, we try to bring as many providers to each visit, depending on what's going on or what the focus will be for that appointment. If that makes sense. But it evolved into that, just because these patients have limited transportation. They're very complicated. And it's, you found yourself seeing them, but not being able to offer really any kind of recommendation or plans until you talk to the other specialist. And so we, with endocarditis patients are the most we commonly need input from infectious disease, cardiac surgery, cardiology, and then social behavioral health, because a lot of them, majority will have some sort of substance abuse.
The other thing that's nifty about these patients is they come from all over Oklahoma. So it's really impractical to have somebody down in, down in Ardmore, just running back every other day to go see the cardiologist, go see the surgeon, go see the dentist. I mean, it just kind of, one of the integrated behavioral health things has been able to try to link them up, particularly with behavioral health and substance abuse providers, but other kinds of services in their area, South Central Oklahoma, or wherever it happens to be. So that's been, I think that's been a key thing that's been kind of helpful. And then they, from the behavioral health substance abuse side, the $1 million question is when's your best bet to do surgery? Is it after they quit, 30 days after they quit? Is it 6 months? Is it when they've been on Suboxone for a year? I mean, and so there's this balancing the cardiac condition with where they are in recovery, because Ronnie talked more about this, but there's about a 90-day window there after the surgery that if they go back to substance use, and she can explain all that about, the outcome is really, really poor if they go back to substance after they have an artificial heart valve. So there's some of this pressure on the substance abuse mental health guys to figure out, to balance that with, when is it safe to go ahead and do surgery, and, their heart condition, how long will they last? And so we've had some people string out forever. We've had some people get in pretty quick. That might be something we kind of look at. Roddy, you might want to talk more about that. I don't know.
Yeah, I agree. I mean, just off the top of my head, without really objectifying it, just most of the patients that I can think of that were done inpatient in the setting of the first, their infection, and they didn't go home, and they didn't go through any kind of behavioral health interventions, they relapse. Most of them will within the first couple months, and many of them will reinfect. And most surgeons and these artificial valves have no natural immunity, and once they become infected, it's no matter what kind or how long of duration of antibiotics you give, they can't. The valve just continues to deteriorate. and the mortality rate is extremely high. And there's very few surgeons that will reoperate. Because it's a very complicated redo operation with a even higher mortality rate when they reoperate, and they don't want to be the forget what they call themselves when they do that. But anyway, so that they don't feel good about the patient dying after they operate on them, obviously. So finding that sweet spot, like Dr. Brand said, and maybe it's just so individual that it's very difficult to determine, but there's probably some sort of characteristic or markers, mile markers that patients can meet. Some will meet faster than others that we can identify and help guide the timing of intervention, because that's the argument. Here in Europe, from a cardiac surgery standpoint, is when should you do it? There's some that will argue you should do it as soon as possible, but we can see that they relapse, and then you may have saved them for a month or two, but then they haven't processed or dealt with the problem that got them there in the first place. So anyway, then they end up dying after lots and lots of surgery and long hours. And anyway.
So the bigger, so kind of the bigger picture for me on this is that if we were able to nail down that it costs X bajillion dollars, on this to manage these patients, it looks to me like then it'd be a much easier case to make, easier situation to make the case for, we need an addiction psychiatrist who consults on these cases, because when you read the literature, it's pretty clear that addiction psychiatry, needs to be involved in these cases. And, OB high risk clinic, with over there, but it's just kind of amazing to me that, an academic medical center of this size doesn't have an addiction psychiatrist that's on staff that consults on these and has an ongoing kind of clinic. So part of my motivation was to demonstrate how costly this is. And, if with the right personnel on board, if you could reduce it by 20%, you'd pay for the cost of the personnel.
It's a lot to take in. Thank you for that background. I think it might benefit us next to look at some of the patient counts and then just organically see where that conversation leads us. But yeah, I learned some new things in that 15-minute description, so I appreciate that, and it might affect where we go with the analysis. Geneva and Ashley, why don't we pull up the patient counts for endocarditis and IDU? And actually, I have a question for the two of you. Did we look for any evidence of intravenous drug use when we made that query, or was it just drug use more generally?
I think more generally.
Okay.
And
these are patients with any substance use concern, and they've got a diagnosis of endocarditis. Is that right?
Correct. And you can see this is sort of the initial file still to be reviewed with diagnoses that we think might be related to drug use. And then I think there's a different category for endocarditis. So this was a starting point. These probably need to be tweaked a little bit. And we can send this out to the group for input. It will be easy for us to change, to remove or add to this if we need to. But we started with this. The time period we're searching is 2010 to September 2021. Patients who are 17 and older. So we required they have a diagnosis, and these could be, this is looking for diagnoses in the centricity problem list, a Meditech diagnosis, or even from centricity building. So 3 different sources, if you will. And requiring that they have one of the codes for drug use and one of the codes for endocarditis. And this resulted in 644 patients. So we didn't have any ties to visits, locations of care, or anything like that.
So Roddy and then Dr. Brand, do have any thoughts on where we're pulling these diagnoses? So again, this is coming from the centricity problem list, the Meditech problem list, and was it GE centricity too? Is that what you said, Ashley?
Yeah, GECD billing.
The billing. Okay. So those are the three sources providing information. Anywhere else we ought to look to find diagnostic information for these
You
patients?
could look at, I mean, you could, in the echo reports, which is housed in Verisys, you could, sometimes the word vegetation will come up in the setting of endocarditis. And then from there, but I mean, it won't have anything about their substance use history. So you're trying to marry the two. But that'd be the only other source that I could think that you might be able to query. I mean, I could use that to query do what we call an echo alert, where I query patients who have severe, aortic stenosis or regurg, different, just to make sure where the ordering providers are notified on the patients who have significant disease. But I've always, sometimes, but I don't know that they use it in a text format, or if they pre-text it on the word vegetation. Or mass would be another word that they often use, because they really can't definitively say it's the vegetation versus a blood clot versus anything. So sometimes, depending on who is reading and what, they may just call it a mass. But it depends on how broad of a net we want to cast.
So David, can you just quickly repeat what Ashley said? I had trouble hearing her. She said come into.
Yeah, our three typical sources for diagnostic information are the problem list within centricity. So that's your OU clinic side, the old OU physician side, right? And then Meditech for the hospitals. They've got a problem list as well. So we're combining those two. But we also are looking at the billing side on, remind me, Ashley and or Geneva. So GE billing, is that clinic only? We have some hospital data filter over, right?
Correct. So it also contains the professional component of hospital billing for a select group of providers, not all.
Yeah, most of these patients will be going through the PPOB or resident clinics, I think. And then of course our clinic, which is a hospital owned or has, well, now I don't know what we are, but anyway, most of these patients will be in Meditech due to their social circumstances. They're under or uninsured. And historically, those patients have not been followed by OU physicians, clinics.
But what did it pull, David?
They what?
Dr. Bard, yeah. So how much data? I mean, so have you run this and you got numbers, or
yes, 644 is the number we landed on. Those were unique patients, right, Ashley?
Correct.
And then Geneva, you were gonna, and I didn't. We met the hour before this, and I gave a last-minute request to look at a timeline. Any progress there, Geneva?
Yeah, I've got a plot for you. Fine.
Okay, great. So these are patient visits by, is it quarter?
By quarter, yeah.
For that 644. So it looks like the earliest we have is post creation of the clinic, if I'm reading that right. So that's 2015. So using this method currently, when we pull any diagnosis of endocarditis in those three sources and any evidence of a substance abuse problem, this is what we get. 644 patients dating back to 2015, looks like the last quarter of 2015, and then all the way up to present day.
That sounds like a good pool.
I would say that's worth working with. I mean, so those have a substance abuse disorder and endocarditis is. So is there a way to pull a second group that maybe has some kind of endocarditis problem and a mental health problem? So you'd have two. I'm kind of interested in the mental health stuff in addition to the. I'm just curious.
Yeah, I mean, we could do anything your heart desires to some extent, right? We just need codes for it. So we would need to know when you say mental health problem, exactly which codes you want us to include in that catchment.
Okay.
Does it bother either of you that we don't have any patients prior to 2015?
So I might have a proposed explanation for that. I'm just quickly scanning through the diagnosis list, and the vast majority are 10s. There's a few ICD-9 codes for endocarditis, but I don't see any ICD-9 codes for drug use. So that might be why we don't go back prior to like when ICD-9s were being used.
Oh, okay. Do we have those mapped? Can we add those in, the old ICD-9s?
I'll have to search for the drug use ICD-9 codes. I mean, we certainly have them, and we can add them in. I just don't have them in this list currently.
Okay, so this list could grow, and we could have more patients prior to 2015 as well. Yeah, I mean, for sake of the analysis, it'd be great if we had patients that came through the system prior to the start of the clinic.
Mhm.
And then what I'm hearing earlier is that there are kind of two cutoffs. There's the beginning of the heart clinic, and then there's the formation of a truly interdisciplinary version of the heart clinic. Eventually, I think we'll want to sort of isolate a pretty precise date for those two transitions.
Mhm.
These are unique patients, so of course they do come back in the system, and we easily capture that. In fact, they probably are in that query. They're just eliminated for sake of this histogram. But we can look at readmissions for all of these patients. We should be able to gather how many of them had surgery. The outcome of that surgery could be tricky, and that's where we're going to need some help. So, anything that happens post-surgery while still inpatient, we ought to have a record of. But when they leave the facility, we're open to your advice on how do we track outcomes for those patients, because some of them may not come back because there was a poor outcome. Some may not come back because it was successful.
So these are patients that have both diagnoses, right?
Yeah, and so we're not looking at how many had surgery at this point, or even how many came through the clinic, although the team did look at that.
Well, let me ask you, so if for the sake of a comparison group, would it make sense to have endocarditis patients who didn't have a substance abuse problem and take a look at some of the same variables to see what the difference is in terms of relapse, time to surgery, missed appointments, and all that?
Yeah, exactly. I think that's the direction we're headed. If we could find enough of these patients, which it looks like we have with 644 and a list that might be growing when we add the ICD-9s in. Do the outcomes for these patients look different before the clinic existed, before the interdisciplinary component was created? Yeah, I think that's one objective I definitely would like to pursue in the near future.
Because I would nearly see it as kind of nested. There's endocarditis patients and what their course looks like, their cost without any use, and then there's endocarditis patients with intravenous substance use, and then there's a subsample of that had behavioral health integration case management, and a comparison of those outcome factors to those three groups. If that makes sense.
That does make sense. Okay, good. So that's a good segue here. I think we want to talk about how do we capture that reliably? How do we capture which patients showed up in the clinic, which patients not only showed up in the clinic, but also had a consult with the integrated behavioral health team? We took an initial stab at that, right, Geneva or Ashley? Maybe not. Maybe I made that up.
Sorry, I was on mute talking. We searched for all of the patients who had a visit in Meditech where the location of care for that visit was Valve Clinic. And so that was, I want to say, about 1,900 patients. And
That's
then, or sorry, 1,900 patients that were seen in Valve Clinic. And then we also just took a handful of patients, less than 10, Dr. Brand, from the log that you sent us. And we tried to search for those patients specifically to look at their appointments. We could find some of the patients. I couldn't necessarily match on all of the service dates that were in the log, but I'm not sure I fully know how to interpret the log. Like some of those services may have been phone calls or other things that may not have a visit reflected in Meditech. So
Right.
maybe there are reasons for that.
Yeah, I think the main thing is being able to track the patients and off the patient name. Some of the stuff will be pretty good, like the GAD7 and the PHQ9 and all that kind of stuff. But yeah, some of the what goes into that database in terms of dates are kind of sketchy now. You know, there is one thing that would be a difference is most of those patients had a psychiatric consultation. So somewhere along the way, they had the valve team clinic had a consultation with the psychiatrist about how to manage that patient. So it might be interesting just to note, you know, did that make any difference or not in terms of medication management and any number of kind of things. So we could pull we can combine that log with what you're doing to tease a bit of that out.
Yeah, maybe we can talk about that in more specifics now. How many different specialty consults could a patient have who shows up in the clinic and has drug use and endocarditis concerns? So a psych consult would be one.
Yeah, psych, cardiology, cardiac surgery, infectious disease.
Dental?
And for a while there, we had dental, but I think Dr. Malassero's kind of gotten promoted to dean now, so he's a little busy.
But some of them would have had dental, right?
Yeah.
Okay.
Yeah, he came around for a while. Yeah.
Okay, so I've got what, 1, 2, 3, 4, 5 there. Cardiology, cardiac surgery, dental, psychiatry, and infectious disease. Does that cover the gamut?
Yeah. And then social worker, behavioral health, however you want. I mean,
yeah.
You consider that the same, or you consider it separate from psych?
Would that be in addition to the psych consult, Dr. Brand?
I think it'd be in addition to, because the psychiatric consult is really for the physician to chime in on medications and juxtapose medications, even on some of the withdrawal symptoms if they've had substance use and how that interacts with the cardiac medicines and those kind of things. It's for the behavioral health stuff, the integrated behavioral health, clinical social work stuff is really about organizing the case and supporting them. So I wouldn't lump those two together. I would keep integrated behavioral health and the psychiatric consultation separate. And that's the way Medicare looks at it too.
Now, if they have these concerns, endocarditis and drug use, would they get all of these consults? I mean, is that the ideal scenario? Or is it really dependent on other characteristics of the case?
You're going to have surgery. I think they get it all, don't they?
Yep.
And if they've got the infection, if they've got the infection, we're going to do the surgery no matter what? Or are there some situations where
if they have the infection and they can prove that they're working, they've made the steps for sobriety. I mean, there's different scenarios. Sometimes the infection doesn't heal and it doesn't cause severe valve dysfunction. Sometimes the infection heals and the patient has residual severe valve dysfunction and they do still require surgery, but the ideal, if they have a condition that is compatible with life, even for the short term, we like to try to get them to work as many steps or to maintain sobriety before and after and the recovery from the surgery if they go through surgery. Surgery is the mainstay. There's really not any good less invasive options for these patients who have endocarditis.
Don't they, Ronnie? Don't they rate them on a scale of 1 to 4 something in terms of not quite so severe to severe requiring? I mean, could we use that as?
Yeah, I think it's Duke. Yeah, there is a score at Duke, I believe it is. I think it's let me check. Actually, Duke might be something else. Hang on. I think so many cardiology has got so many scoring systems.
But that's in the record, isn't it?
Yeah, it should be.
that'd be great.
Form is mild, moderate, severe.
Yeah, it is at Duke. I was right. I was thinking it's Duke, DUKE criteria for endocarditis. Now, as far as whether or not to do surgery, there's a lot of subjectivity. So
But
there
that's
are
still
some
kind of-
algorithms though and protocols.
That's
Huh?
kind of an objective way to grade the valve damage, isn't it?
That's to determine, I think it's early on for endocarditis and how bad. I'll have to look for the valve damage. I don't think there's a good, most of them is the patient stable? Do they have major, is it a complicated, so have they suffered a stroke from the event or from the endocarditis? Have they suffered another sort of embolic event? Do they have heart failure or heart block? Is it associated with there's criteria, and if it's associated with any of those criteria, then there's a low threshold for going for surgery early on. But most of those studies were done in patients who were not drug users, and they were, got it from, going to the, bad hygiene, and then they lost too roughly and got an infection in their bloodstream from their gum tissue. And that's historically what endocarditis was usually caused by, but now they're getting it.
So what's that Kansas City rating scale you all use?
Oh, so the Kansas City cardiomyopathy questionnaire is, we use it for our valve replacement to compare how impacted a patient felt, like in regards to fatigue, shortness of breath, swelling, so heart failure type symptoms before they had surgery, and then a month after they had surgery or a valve replacement, and then a year after, to see what it's subjective, the patient's perception of how impacted their quality of life is, their daily activities and such are from what they perceive as their symptoms.
So, I mean, you could use that, and you could use substance abuse severity, or you could use mental health problems as an intervening variable on that.
We sure could, yeah.
Talk about standardized kind of way to guesstimate how much substance abuse may have impacted their recovery before, after, and later.
Absolutely. Yep.
So if we go to fish these out of the system, where would we find, let's say, the Duke score? Do we know?
So I don't see, I see them on the outpatient side. I don't see them on the inpatient side. Duke is usually calculated inpatient. It would probably be on a cardiology consult note. I don't think you'll see it much from an ER type setting. God, it's going to be in the body though, Meditech. I don't know how easy that is to search. You think it, I don't know. But everything is.
This is why we anticipate.
Yeah, chart review. Yeah.
But the cardiology.
And we can look. There may be other scoring, but there's not a, if Meditech would, like, if you inputted that data and it would put it in, a lot of newer systems dump it into the node automatically if you input those answers. But this one, a lot of times they'll just calculate it and never document it. They'll just go back anyway.
Could you connect us to somebody who would gather that information and input it so we could find out how they do it?
Yeah, we could see if we could calculate why we're, we could look into that. On the cases that we review, we can try to get as much, because I know as much objective input.
Would that be what the students would do? Would be comb through the records to try to pull some of that stuff out?
Yeah, the students can go through the record. Nice to have somebody who creates those cardiology consult notes. Yes. Yes, that's where we put it, and this is how we do it.
We're happy to help with that, because that's what we do on a regular here.
So now, what about the Kansas City rating scale? Where would we find that?
That is going to be scanned in, or that actually is in my notes. There's a frailty section, and all my notes have been historically in Meditech because I'm a hospital employee. So, but I don't know. I'll have to show you. See, I don't know what you can bring and what you can't, because it's part of the note component. And I input that it was done. The actual paper trail itself is usually scanned into what they call HPF, which is the hospital's official quote unquote medical record, which is a whole, just when you think you've found everything, there's a whole nother place.
Would it be possible for you to send us a screenshot of the documentation you do in Meditech on just one patient? And then sometimes that's enough for us to back into where it exists in the chart.
Okay, yeah. Okay.
Yeah, I was about to say, I'm the wrong person to be asking these questions. Ashley or Geneva do this for a living. So they're pretty good about finding these things once we see a screenshot or it can sit beside somebody and watch them do it.
Just send it through like an email, or how do you want me to get it to you?
You can send it by email. Or you can send it secure email.
Okay,
Either
way. You're in
fine.
HSC, aren't you? System. Yeah,
Yes.
I have both emails, so either way.
What about the consults? Where would we find those, that they exist? What's the best indicator in the system? Do we have a referral first and then we actually have the completed consult? Is there a way to distinguish that?
So not very clear, because so operating as a Meditech's a hospital-based, an inpatient type clinic, a medical record, and they had us using Meditech for an outpatient type, an outpatient setting. So it's there. I do have notes. They're called valve clinic notes in Meditech, and if there's a valve clinic note, and they do cross over into EMR under a category called P and an NOT, or I think it's progress notes with an S on the end of notes, because there's progress note with no S, and then there's progress notes with an S, and it's the S on the end of notes, and they cross over in that category in EMR, and they're called a P and then capital NOT, T note. But so usually if I go into EMR, I'll just click on the progress notes tab, and then it isolates the valve clinic notes. There are a few other things that cross over as provider notes, I guess is what the P stands for, but I'm only speculating. Anyway, some other, they used to have a geriatric clinic, so you may see some of those notes get muddled in there, but otherwise you should be able to see them. The header on the note is going to say valve clinic, and I've never changed the header even as we evolved. It took 1.5 years to get it to cross over, so I wasn't about to re-embark on that.
Ashley or Geneva, you have questions on that one? You want to see a screenshot of that?
I think we've seen it. When we looked for documents in Centricity, I want to say the document summaries were all really consistent and had valve clinic in the title. So I'm following what you're saying, I think, right now.
Okay, good. Yeah.
Hey, Rowdy, while we're talking about it, does Dr. Abdello, does he use a rating system on the severity of the ineffective carditis?
I haven't seen him routinely use it. There are rating scales, and we can talk to him about maybe, just going back and calculating those out on on as many of these as we can or choose to.
Because I think the more standardized kind of instruments we use in medicine or behavioral health, the stronger the results.
Yeah.
And you provided the list already, Dr. Brand. Ashley, you provided us a list previously. I don't know if you remember that or not, but Ashley and Geneva, how many of those were we able to find?
We haven't searched the entire list. We were waiting to see to sort of clarify the search process for included patients. We've only searched for a handful. So we just took a small sample from that list, like 10 patients, and searched for those. And we found, I don't know, I want to say initially it was half of them, but we were focused on the patient and the visit date, not just the patient. So I'd have to go back and look if we just look at the patient level.
Yeah.
Knowing that some of those visit dates might not be in person.
Right. Yeah, some of those dates, depending on which flow sheet you were looking at, we had to do with when the diagnosis was made, and usually they were inpatient, and then there were treatment dates. So yeah, it was not the date I necessarily saw them but just to, because the concern at that time was how long were these people going between the diagnosis to the surgery, and if they lived or didn't live, you know, at that point when that was initially constructed, because their thought at that point was we're having them wait too long, and if we would have operated sooner, they would have, you know, maybe they would have done better, but it's really, it's debatable.
We're getting close to the end of the hour. What are the chances we could get together again in a couple of weeks?
Okay.
So let me ask, maybe this is for discussion for next time. Dr. Song, I mean, do you think undergraduates are going to be able to tease through this with Rowdy, or are you going to need graduate students, or what level of, I don't have a feel for the level of sophistication and, you know, the different students have.
Great question. If they're searching for a Duke score and a clinical note, what, you know, are they going to need some kind of medical background?
You asking me?
I think so.
Yeah, I've so just from my experience, you know, when I first started this valve stuff, you know, repetition, you know, is, you can teach anybody, I mean, to find anything if they're doing the same thing over and over. So I did a retro analysis on just AS patients in the past, and I had the girls that helped me at that point were medical assistants, not college educated to any degree. I mean, you know, all they had to do is I have to make sure they understand why and what we're looking for, and they have to have an interest. I think interest is the most important thing. It's, you know, if they.
So are you going to have a place to set these folks up on some computers over there? And
They should be able to come. We should be able to isolate this room. We'll have to come up with a good day of the week that works. I mean, there are certain Fridays of the month where we don't have any physicians here, you know, or clinics. So whenever I'll figure out what days we have the Fridays, but it's not every Friday, or usually generally the day when we have the least amount of doctors here. And this room has 1, 2, 3, 4 computers. I don't know, how many are we talking?
I don't know. And you feel like you're going to have the time to kind of monitor and supervise those students?
I think is it the same people throughout the process, or are we?
Yes. Yeah, we're looking to get, you know, as many students as we need, but I would think 2 to 3 for this semester to come up there once or twice a week. If you could just show them, you know, this is how to do it. I think within a couple of rounds, you can figure that out.
Yeah, I think once we get the system down and teach them, I mean, there's going to be time in the beginning, but after that, I mean, I think, you know, I have nursing, you know, advanced and nurse practitioner students or whatever that come through, and I have them do retro analysis, you know, for me on other projects. And, you know, they ask, there's a bunch of questions in the beginning, but eventually they get a routine and they figure it out on their own.
Dr. Song, you think that's kind of within the scope of undergraduates?
I'm sorry, I missed some of this conversation because my son would just interrupt me constantly.
Okay.
And the internet did not work really well, and I have to re-log in a couple of times. So do we say that the undergrad student we recruit have to have a medical background or pre-health or med, that kind of thing?
We didn't force that requirement. I think we'll be better off if that was not required, but you know, if it is, then we'll try to find maybe some pre-med students.
I would think
that would be good.
More interested in this kind of, you know, positions than the student from psychology per se, right? Yeah, they're just some kind of the things we can think about it. In terms like the format of a work, I think that is very doable, and with the help and from you guys, and that can be done.
So Erin Mayer, who's not on today, agreed to find us students. Now she's in the Department of Sociology. She thought about social work as well as potentially being a recruitment spot for us. But I think we need to see how difficult is this before we approach any students. So that's why I was hoping we could meet before the month is over. We'll go look for some of the things I learned today, and just for the groups, I guess I'm throwing out my understanding of the direction we're going to go next. You guys help me edit this. I'm tempted to work with the 644 we saw, see if we can find some prior to the 2015 date with the ICD-9 codes. And then for each of those patients, try to figure out how many got a cardiology consult, cardiac surgery, dental, psychiatry, infectious disease, social behavioral consult, and sort of create an index of this is how much of integrated care that patient received. And use that index to correlate with outcomes. And we'll look at readmission rate. We'll look at endpoints from the surgery. We can get our hands on these rating scales, especially that Kansas City rating scale. We'll use that as an outcome. And then some of the other indicators that Dr. Brand provided previously too. We'll try to uncover as many of those as we can. Whatever we can get in a structured field with EMR, we can have ready to go, within the next couple of weeks probably. If it's buried inside a note, we're going to need those students' help. And so we need an exhaustive list of what we want them to go find, where it's at, and then we'll work out the logistics on getting them to campus, training them, and then where to put the abstracted information.
So David, right now you want to focus specifically on the endocarditis and the substance abuse?
I think we have enough of those. I'm open to the possibility of expanding the criteria there. Keep in mind, or bear in mind, I guess, that we have limited time to expend the funds. I think we have to have the money spent by June.
Well, let's go with those patients, and if we have time to go back and look at other substance use and mental health problems, then we can just use the same framework and run that then. But let's stick with what we're talking about.
Okay. Okay, I really appreciate your time. Lisa will be in touch soon, and we'll try to get that next meeting scheduled. And then we'll dive into some of these details.
The only other thing I'd feel more comfortable with is whoever's going to do the cost analysis. That they were involved a little bit in the discussion. They may be doing that privately with you, because there may be things that they think of that I don't have any clue about, because that's not my area.
Yeah, we'll try to get June on the next call. So Lisa, let's make sure June is available for whatever date you book.
Okay, and that's June. I don't think I know this person.
I call her June because I can't pronounce her name well.
Okay, I think I know who you're talking about.
Faculty member from public health.
Okay.
She's given me permission to refer to her as June, so I'm taking advantage of that.
Okay.
I thought her English name is June.
It's close. It's not exact, but yeah, I've butchered it at times that she said, just call me June.
Got you.
Okay. I'm sure you guys have other meetings to go to. I do too, but it's great to meet you, Rhodey. And thanks everybody for your time today. See you in a couple of weeks. Okay.
Nice to meet you.